Okay. This tape is 6 minutes, and it will be everything we've done in real time for a P branch. The P branch is a new off-the-shelf. I think Dr. Tadros alluded to it in his initial discussion, but it's one that will potentially allow us to treat aneurysms that involve the perivisceral area, but not have to wait 3 to 4 weeks to get a new graft created. So basically, it's a pivot fenestrated stent graft. This goes back to looking at the basic design. Facilitated juxtarenal and perirenal aortic repair. It comes in an A and B configuration, a Dacron woven graft, with everything really being based off the SMA. It's 26 to 36 millimeters in diameter with 2 fenestrations, scallop configuration as mentioned, and then you have it based on the SMA and then the renal arteries in 2 locations. Here's the basic pivot graft. Nice thing about it, you have a through and through wire going from one renal to the other, and then flexible pivot to allow you to have greater variety of positioning for the renals. The SMA is your point of orientation. Also, you have the sheaths coming in for both renals in the same introducer device, so you can have one large iliac and not have to worry about trying to go up with both sides. This is a 74-year-old male evaluation of a 6 centimeter aneurysm, coronary disease, renal dysfunction, hypertension, hyperlipidemia. CT again shows the aneurysm really going up to the level of the renal vessels. You can see in both lateral and apical views. Here you can see the aneurysm really going right up to the left and right renal artery. Iliacs were of adequate size. Here's the 3D reconstruction of the aneurysm, again showing it being a perivisceral or perirenal aneurysm. The angiogram was obtained, again, showing takeoff of the renal vessels, sizing. This does have a little bit of a shotgun appearance, being one of the earlier P branches. We've kind of decreased the number of markers here, but really lets you line up with a large scallop for the renal, for the celiac, and then fenestrations for the renals and SMA. Then you can come in. Really, it's just everything is based on the SMA. We have a guiding wire here for the left renal. Can orient the graft, unsheath. Again, you're going to be orienting it such that the SMA is your main configuration. Through and through wires let you come up and bring your sheath right up to the fenestration, and you don't have to try and catheterize in the fenestrations, and it holds in place. So yesterday you saw how the wire kind of pushed out. Here the sheath is actually held up against the area of the fenestration with the through and through wire, which comes up and over and down to the other renal, allowing you to have very precise manipulation with your wire. Here we have the curly Q catheter going out, an 035 wire going out, giving you good strength. You can't advance the sheath out until you get the through and through wire, but you can certainly park your catheter there. Then come up the contralateral side. There again, you bring your sheath right up to the fenestration. You can come out with your curly Q catheter here, be able to manipulate it down and then access the renal vessel as done here. You can slide the curly Q catheter out or exchange for a Trailblazer as we did in this case. And then you come out with a Rosen support wire to let you have good purchase into both the renal vessels. You then can come in, and generally I do the SMA first. This case we happen to do SMA as third, but you can come in here, cannulate through the fenestration into the SMA. This is done from the contralateral side, so really the only catheter sheath you're coming up from the opposite side, and then just work through that and take your wire out into the SMA. So this then lets you have all 3 of your vessels accessed. Here's the larger sheath going out in the SMA to assure your purchase. And again, everything, you base it on the SMA being at 12 o'clock, and then everything else comes from there. You then have a large scallop for the celiac here that's released. The introducer system is back down. You can then deploy your balloon expandable or self-expanding stents, however you want, in for the visceral vessels. Coda that area to get a better seal. Generally, you want to do that before you've deployed your stents, as we're doing in this case. and then you come back again, giving good overlap into the area of the aortic graft. There's a renal stent going out, and we did that sequentially for both renal arteries, then come back and you, by protocol, we use a balloon expandable covered stent for the SMA also. Sometimes you don't have to, but by our protocol we did, and there again you have seal there going into the SMA. Both renal stents are in place. It has diameter reducing ties, as you've seen with the other fenestrated grafts. You deploy that, and then you can come in, and the remainder will really be just as a standard infrarenal EVAR building up, or a Z-fin with component coming down into the iliacs. There's the contralateral gate here. We've accessed the contralateral gate, and you'll come back and you do retrograde angiograms and then deploy down to the level of the hypogastric, as we've seen with Z-fins already. I think in interest of time, I'll move forward from that. We have had prospective randomized trial looking at the fenestrated graft for juxtarenal anatomy. And basically here again, it gives you the graft, the design. You have to have the aneurysm stop at the level of the SMA or 15 millimeters below the celiac, depending on the protocol. And here's the graft again showing the flexibility of the pivots, so that once you've oriented on the SMA itself, you can really have the renals be upward going, straight lateral, or downward going to really give you that versatility as you're dealing with it. And I think I will forego going through the data just in the interest of time.
Thanks a lot, Jim.